Yeah, thank you. Thank you so much. And no worries. We're going to practice pronunciation during
Yeah,
the talk.
this Zoom thing is kind of intimidating sometimes.
Yeah, absolutely. Thank you for introducing me. Like you said, my name is Don Phillips. I'm one of the pediatric epileptologists at CHOC. I have a special interest in epilepsy and cognition, so I'm going to talk about that today. And I this is meant to be very interactive. I only have about 20 or so minutes worth of actual slides to kind of just set up a framework for discussion. So please, uh, you know, uh, collect your questions. We can have a good discussion at the end. And if there's any burning questions in the middle, you can interrupt me too. Okay. Let me see. I'm going to turn my subtitles on because I know sometimes kids come in the room and you kind of miss what's going on. Um, I don't have any disclosures. So, like I said, we're going to talk about epilepsy and cognition today, but it makes sense to take just a moment and talk about how we define epilepsy because you can look at the definition of epilepsy and kind of see how we treat it and how we think about it from the definition. This is my favorite definition of epilepsy, and this came out in 2005 from the International League Against Epilepsy, defined as a disorder of the brain. So that's good, got that. Characterized by an enduring predisposition to generate epileptic seizures, so you need seizures, and by the neurobiologic, cognitive, psychological, and social consequences of this condition. And I think that's key because we don't talk about that enough. And I think the reason, in part, is because of how we think about epilepsy on a more practical basis. And so there's a practical definition of epilepsy that actually allows you to diagnose it, and that has it's everything to do with seizures. So a disease of the brain defined by any of the following conditions, at least two unprovoked or reflex seizures occurring more than 24 hours apart, one unprovoked or reflex seizure, and a high probability of having a next one, or having an epilepsy syndrome. So there's nothing in that definition that talks about memory, cognition, behavior, psychiatric disorders, psychosocial, anything. And I think sometimes we get stuck in this operational definition of epilepsy, thinking about seizures exclusively. So when you're comparing kind of a more of a conceptual framework to a practical one, my thought is that the practical definition is for making the diagnosis initially, and then we should put that away and then work off a conceptual and more holistic definition of epilepsy. Certainly, in treating epilepsy, we must attend to the cognitive, communication, behavioral axis of the disease. So, just not just seizures, but those other things as well. So, I actually think of epilepsy as a spectrum disorder, just like autism. There's a lot of different causes feeding into epilepsy, just like there are autism, but there's a broadly shared disease experience. Aside from seizures, there are other things we know to look for as well. At least half of those suffering with epilepsy have associated cognitive or psychiatric impairment. And that's epilepsy, adult and children. I would wager that the pediatric group has even higher than half being affected. The degree of impact may vary from person to person and may vary within the individual over time. But if we think about epilepsy as a spectrum disorder, then we start thinking about these other things that can go hand in hand with the seizures. So, indeed, the spectrum should be thought of as multidimensional. And here's just a few. Other than seizures, we have a cognitive axis, a behavioral axis, a social axis, there's a psychological axis. These are different things, different kind of variables that can be affected in epilepsy. The impact in each one of those dimensions can change over time, and it can either be linked to another or independent of another. And so, what we're going to talk about today, this concept of epileptic encephalopathy, is a linked dependency. All of these other uh, psychological cognitive behavioral things linked to my burden of epileptic abnormalities. So to reiterate, epilepsy is a spectrum disorder conferring an ongoing risk of seizure, as well as a risk of cognitive, behavioral, psychological, and or social impairment, which may change over time, either dependently or independently. Thus, all of these different axes should be considered as potentially modifiable treatment outcomes. In other words, you might be able to do something about these other things, either by treating seizures or by addressing them directly. So treating seizures is necessary, but not necessarily sufficient to optimize our overall outcome. So encephalopathy, big word, very general meaning. So it's any diffuse disease of the brain that alters brain function, may impact memory, cognition, learning, personality, behavior, ability. Maybe global or more focused. So global encephalopathy is kind of affecting all domains, but there may be encephalopathy that affects something specific, like our memory, or like our attention, or even motor function, or something like that. They can be reversible or irreversible. So if someone is admitted to the hospital with sepsis, a body infection, high fevers, that sort of thing, that person has an encephalopathy. They're confused, they're not themselves, they have altered level of consciousness, but it's reversible. We expect that when we fix the underlying infection, that the encephalopathy also reverse. And then static versus progressive. So some people have a static and long-lasting encephalopathy, others progressive, others, like I said, can be partially correctable or reversible. When we're talking about encephalopathy as it relates to seizures and epilepsy, one of the big topics we talk about is epileptic encephalopathy, and this is a super confusing topic. So the modern definition of epileptic encephalopathy is that the epileptic activity itself negatively contributes to the cognitive and behavioral impairment above and beyond what you would expect from the underlying pathology alone. Example, if I have a stroke on one side of the brain, I expect to be weak on the other side of the body. I don't necessarily expect that to cause developmental regression 3 months out, or worsening weakness or something like that. So an epileptic encephalopathy is above and beyond the underlying cause, a negative impact that the seizures or other epileptic activity may be having. The global or selective impairments may worsen or fluctuate over time, so it's not static necessarily. May be seen at any age along any spectrum of severity and across all epilepsies. And that's key. So we talk about this list of epilepsies called epileptic encephalopathies, and I have a list of them later, but West syndrome with infantile spasms, for example, is on that list. But truly, almost any epilepsy is capable of manifesting some degree of epileptic encephalopathy, and it's something that we have to watch out for. So because these things are potentially dependent upon the underlying seizure activity or other epileptic activity on the EEG, they may be modifiable. We may be able to make them better. And that's the reason we're talking about this. That is in contrast to what we call developmental encephalopathy. And so just kind of taking a step back, that epileptic encephalopathy, although that term has been around for a while, the modern definition only came out in 2010. And this one, developmental encephalopathy, only in 2019. And so these seem like basic concepts, but they've muddied the water for a long time, and we're finally getting some clarity with this, which is why I'm presenting it to you, because I think it's important. So developmental encephalopathy, in contrast to the epileptic encephalopathy, means that the seizures and the developmental impairment that we're seeing in our patient are both arising from a cause that's causing them directly. And the epilepsy is not making the development worse. The development and the epilepsy are from the shared cause, usually a genetic issue. Cognitive and behavioral impact due to the underlying cause, not the epileptic activity itself. Therefore, typically not modifiable with seizure treatment and typically not reversible. It tends to be either static or progressive. We differentiate between the two, number one, so we catch the epileptic encephalopathy, the thing that is modifiable, the thing that we can make better. But also, so we identify if there's a developmental component, so we don't treat aggressively and throw on a bunch of medication or other treatments when there's little hope of actually making a difference. So we want to identify if there's a component of developmental encephalopathy, so we avoid overtreatment as well. So this gives us an encephalopathy spectrum or continuum. You'll see that spectrums are a theme of our talk today. I'm going to see if I can get a little pointer here. So let's use a laser pointer. So on one end of the spectrum, we have the epileptic encephalopathies. This is our mental status is made worse from our seizure burden or from a lot of abnormal electrical activity that we pick up on the EEG. This is stuff that's potentially modifiable. If I treat the epilepsy, then maybe this gets better. On the developmental end of the spectrum, my cognitive impairment is from whatever root cause is happening. I have a genetic mutation and that causes intellectual disability, and it also causes seizures, and those don't make each other worse. Less likely modifiable. And then there's this group in the middle, this epileptic and developmental encephalopathy, where you have components of each. And maybe a good example of that is Dravet syndrome. Dravet syndrome in the majority of patients are from a sodium channel mutation, SCN1A. That abnormal sodium channel or channelopathy does cause by itself some developmental issues, cognitive impairment. So that's the developmental component of that. However, many parents will tell you that if seizures get more active, get really bad, also development starts to stagnate and we may even lose skills. And that's the epileptic side of that. So Dravet syndrome, we would consider kind of in the middle here. And the trick then is to find the component that is epileptic and treat that aggressively, because we can save IQ points there. And the component that's developmental, we don't overtreat. Turn off my clicker here. So I mentioned before that there's this list of things that we call epileptic encephalopathies, and this is kind of older in the literature. These are West syndrome and Dusa syndrome and Otohara syndrome. These are early onset epileptic encephalopathies. These are epilepsies that occur early in life that have a high chance of negatively impacting cognition. Each one of these, though, probably have a pretty large developmental encephalopathy component and may or may not have a component of epileptic encephalopathy. That is something that's potentially modifiable or reversible. And so calling some electroclinical syndrome an epileptic encephalopathy by itself is less helpful. Rather than referring to the actual symptoms of our patient and saying whether or not we think the cognitive challenges they're facing are epileptic and therefore potentially modifiable, or more on that developmental side and not. So again, these are the definitions here. We've talked about this a few times, so I won't read it in detail, but this talks about the difference between what we call epileptic encephalopathy and developmental encephalopathy, and makes room for disease states where we have a little bit of both. Successful treatment of epileptic activity may improve or reverse cognitive impairment in epileptic encephalopathy. That's why we care. But aggressive treatment should be avoided in developmental encephalopathy so we don't overtreat and cause potential side effects from our medication. And so that becomes a very important conversation between the patient and parent and the treating epileptologist or neurologist. How much of what my child is experiencing could be cognitively and behaviorally could be reversible, and how much of it may be a component of the underlying disease state. So our goal is to identify the modifiable component and to treat it to maximize developmental outcome. I included a couple of slides here demonstrating the evidence we have that epileptic encephalopathy exists. All of these bullet points here are a different study. And one of my favorite is over here. Let me put my pointer back on. Over here by Professor Berg. It's a study that shows that in epilepsies that come on before age 3, so early onset epilepsies, 41% of them in their cohort that they studied had a greater than 1 month delay in diagnosis. When they looked at them immediately, they already had developmental challenges. Those developmental challenges persisted for years afterwards. And 8 to 9 years after the onset of epilepsy in these less than 3-year-olds, the ones that were delayed had almost a 15-point lower full-scale IQ than the ones that were treated immediately. This argues that the more delay we have before we start treating seizures and the more time we have uncontrolled seizures, the higher the risk is that there may be a developmental component to this. Conversely, if we act quickly and completely, turn my pointer off, we actually get some good results. So on this, these are 2 different studies here. Each bullet point's a different study demonstrating, and these both talk about surgery, but patients who had their epilepsy identified early and had it treated definitively, in this case with surgery, had better developmental outcomes afterwards. So this last study here, surgery before age 1 in the appropriate patients, of course, resulted in a median 30-point improvement in developmental quotient, suggesting that some impairments are reversible if the epileptic activity is terminated early. So this is important. We want to think about development as a separate and equally important outcome measure when compared to just seizure control itself. You need both, ideally. So in these slides, I've talked about epileptic activity. What does that mean? So the tip of the iceberg are the clinically recognizable seizures. These are things you see at home. Below the surface, potentially, is an occult seizure burden. So seizures that are either completely subclinical, they have no clinical manifestation at all. You cannot see them outwardly, only the signal in the brain, or seizures that are very subtle. So if you're not looking at the child, you're not going to see them, or seizures that occur in times where you're not looking, like sleep. In addition, there is what we call interdictal epileptiform burden. So these aren't the seizures, but these are the sparks, the abnormal electrical activity. If it becomes dense enough, frequent enough, disruptive enough, then it can also itself, even though you're not having overt seizures, can still disrupt cognition. And this is especially true in sleep, and especially slow wave sleep. So there's this concept of electrographic status epilepticus in sleep or in slow wave sleep, where the burden of these electrical abnormalities, not seizures, but the electrical abnormalities, is so high that it's thought to disrupt the normal cognitive processes that happen during deep sleep, that restorative sleep. Now, I know Dr. Pichon talked about ESES a couple hours ago, and so I'm not going to talk about ESES in detail. Happy to answer any questions about it. But that's the concept, that the abnormal electrical activity disrupts what should be happening in sleep. I have a few slides on it later. So, to get the bit of the iceberg that's under the surface, you need EEG. And with continuous video EEG, that is how we truly define and characterize the real and total burden of epileptic activity, including not only the clinically apparent seizures, but the potential occult seizure burden and the burden of the interdictal epileptiform discharges, the sparks. So that's part of it, that epileptic activity burden, getting a true handle on that. The other things we talk about when we're putting someone's intellectual challenges on this encephalopathy spectrum is their developmental trajectory. In other words, has our patient always been impaired and this is just the same thing? Or do we have new impairment, either stagnation, development is we were going up and now we're leveling off, or even regression, losing skills? If there is a change in the developmental trajectory, either stagnating or regressing, we're more likely to be on the epileptic encephalopathy side of the equation. And we're more likely to be able to modify it because there's a change. But the other piece of information we really need is to truly understand the why. What is the cause, the root cause of our epilepsy, or what we call the electroclinical epilepsy syndrome. So we combine our history, our physical exam, our electrical data from EEG, our structural data from imaging. Genetic testing is increasingly important to come up with the why. And if we have something that either doesn't have a big developmental component typically, or does but can also have an epileptic component, and we see a high burden on the EEG or with seizures, and we see a developmental change, we're talking pretty likely that we're on that epileptic side of the encephalopathy spectrum, and we're wanting to probably treat that more aggressively to see if we can reverse or change the course of that deterioration. So just a word on what I mean by electroclinical syndrome. This is the why. This is, sort of my soapbox issue a lot is, kind of one of the biggest roles of an epileptologist is to answer, if we can, why is this happening? I tell my patients I have two jobs: answer the why if I can, and to treat the seizures. And sometimes the treating part is easier than the why part. But what we try to do is synthesize all of the information we have, the clinical, the electrical, the structural, the functional, the genetic, put it all together to form a holistic understanding of what's going on. If we know that, that can inform treatment, but it can also inform what we're talking about here, how likely it is that the cognitive issues that we're facing may be in part reversible or modifiable. So no one test can give us that answer. Genetic testing is important and increasingly touted as essential in our workup, and I totally agree with that. But genetic testing alone is not going to give you this answer. I've listed a couple of examples here. SCN1A, a mutation in a sodium channel, very common among our genetic epilepsies, can manifest widely differently in different patients, ranging from febrile seizures that we outgrow to genetic epilepsy with febrile seizures plus, which is an epilepsy with seizures without fever, but typically in an intellectually typical or normal child, all the way to Dravet syndrome, which has both components of developmental encephalopathy and epileptic encephalopathy, and definitely can affect cognition negatively. So too KCNQ2. There's a variant that's benign familial neonatal seizures that are universally outgrown in early childhood. And there's early onset epileptic encephalopathy, which is not. And so the gene alone doesn't help us. But when we put the gene in the whole picture, we begin to synthesize, again, this more holistic understanding of the why. And that helps us with the next step. So some medications can exacerbate certain epilepsy syndromes. So to use SCN1A and Dravet syndrome as an example, if we put a sodium channel blocker like oxcarbazepine or trileptal on a patient with Dravet syndrome, they are going to get cognitively worse and have more seizures. And so getting to the why is also important, because sometimes it tells us what to avoid. Sometimes just removing that offending agent can reverse some of the epileptic encephalopathy. And again, knowing the etiology may also help inform prognosis, to tell you what to expect, the range of possibilities, and to help avoid overtreatment if at least part of our developmental issues are on the developmental end of that spectrum and not likely to change with the treatment of seizures. So I said I have a couple of slides on ESES. I encourage you to go back and watch the talk. I think it was at 9 a.m. today by Dr. Pichon for details. Very briefly, ESES, electrographic status epilepticus in sleep or in slow wave sleep, is an EEG pattern only that may manifest as an epileptic encephalopathy and can occur in most epilepsy types. Classically, we thought of it as occurring in slow wave sleep and occupying at least 85% of slow wave sleep, but more modernly now, we use a cutoff of about 50%. So if greater than 50% of slow wave sleep is occupied by epileptiform abnormalities or epileptic abnormalities, if we consider that ESES, and we say that there is at least a possibility that that may be negatively contributing to cognition. And just to give you an idea of what we're talking about here, I'm gonna turn my little laser pointer around again. So this is a background during wakefulness. It's not normal. These spiky things here are epileptiform discharges. These are the things that argue for an increased risk for seizure. Each one of these segments between these big vertical lines here is a second. So we have, several discharges per second, but we also have space in between where there are none of these spiky things, no epileptiform discharges. However, when we go to sleep, the discharges activate. We call this activation. And you see in every single second in this EEG, there are multiple epileptiform discharges. So the idea is that this deep sleep, slow wave sleep, is supposed to be where we learn, where we consolidate memories. It's the part of sleep that's most restorative. And if it's disrupted by this abnormal activity, you won't see the outward manifestation of that. It's not going to look like a seizure. It's not necessarily going to disrupt the physical sleep. We're not going to have arousals from it and that sort of thing. What it is putting the time on pillow where you're sleeping, but you're not getting what you should be getting out of it. And you don't know it without an EEG. So when we see developmental stagnation or regression in the patient with epilepsy, we do the 24-hour EEG to look for this. And then depending on what we see on the EEG and depending upon the clinical circumstances, we think about that encephalopathy continuum. And if our symptoms of encephalopathy are worsening, this is something that may be reversible or treatable. So key points from that section: continuous video EEG is necessary to define the true burden of epileptic activity. Defining the underlying electroclinical epilepsy syndrome, the why this is happening, is helpful in determining the degree and potential treatment of epileptic encephalopathy, as well as the epilepsy itself. ESES can manifest as epileptic encephalopathy. And again, I encourage you to look at Dr. Pichon's lecture a couple hours ago. Timing is important. Age of onset, the total exposure time to epileptic activity, it may determine, at least in part, our cognitive sequelae. Okay. There are a few other things I want to talk about today that can negatively affect cognition beyond epileptic encephalopathy. And these are our typical comorbidities to epilepsy. ADHD is a common one. So ADHD occurs very commonly in epilepsy, 30 to 40% in targeted studies. In other words, I designed a study and I go looking for it in epilepsy, and 12.5 to 15% in non-targeted studies. So that is, I look at a cohort of patients with epilepsy after the study is done and look how many of them had ADHD randomly. So either way, if you're talking the lowest is 12.5%, you're talking over 10% in any cohort had ADHD, which is higher than the general population. A little bit different than the general population, the predominantly inattentive subtype is more prevalent in patients with epilepsy. So you'll recall that ADHD has a hyperactive subtype, inattentive subtype. So I'm not paying attention to things, but I'm not bouncing off the walls, and a both. The hyperactive ones get the most attention because they're acting out. The inattentive subtype tends to go unnoticed more. And so that's important in our patient population with epilepsy that already may be a little bit withdrawn for other reasons. There's no gender disparity in ADHD and epilepsy, unlike the general population where we see it way more in boys, although I'd argue that girls are probably just overlooked because the boys are more likely to be the hyperactive component and the girls are more likely to be the inattentive side of things. And we already know that because inattentive subgroup, they're quieter, they tend to be overlooked. Sometimes we see the attention problems before we see the seizures start, so that can be a clue. Risk factors for ADHD in children with epilepsy include having other developmental issues and having poor seizure control. It does not have to do with the seizure type. So this patient over here is having just absence epilepsies. This patient over here is having big generalized tonic-clonic seizures. They're both equally likely to have ADHD. Importantly, the standard ADHD treatments are safe and effective in our patients with epilepsy. And the International League Against Epilepsy recommends annual screening of our patients with epilepsy either after seizure onset or after age 6. Autism is more common in epilepsy. So depending on what study you're looking at, this paper that I'm showing here, I'll turn my pointer on again. This paper here looked at several studies and averaged them all together. So the average of all these studies, 8.1% of all the patients studied in all of these studies with epilepsy had autism as well. And only 0.76 of the general population has autism. So autism is well more common in epilepsy and something we need to look for, something that can negatively affect cognition. Now, classically, and what we always get in a fight with other providers is that classically the diagnosis of autism was not made unless it was somehow pure. If there was anything else that could be contributing, the diagnosis was not made, which is a big problem with our patients, all of whom have epilepsy. And so Dr. Jesty up the road at UCLA did a great study with tuberous sclerosis. This is it here, that demonstrated that the autism in tuberous sclerosis, what we call syndromic autism because I have something else, and autism itself, idiopathic autism for no other reason, what we call non-syndromic autism, the symptoms overlap completely. They look the exact same. And thus they should be treated the exact same. And we should make the diagnosis when it's there because it gets us therapies and it gets us treatment, and early intervention has the best outcomes. So identifying autism, if it's there in our population, is extremely important. Sleep is huge. Any new parent, or if you remember when you were a new parent, knows intuitively that chronic sleep deprivation negatively affects cognition. My kids are 4 and 6. I don't think I've slept in 6 years. And we know that sleep deprivation makes us feel stupid and angry, essentially. Imagine our kids having sleep issues going undiagnosed, walking around with essentially chronic sleep deprivation. That can't happen with epilepsy. We know, and we continue to discover, that there's a higher incidence of primary sleep disorders, things like obstructive sleep apnea, in epilepsy that have nothing to do with seizures. So our kids are walking around functionally sleep deprived, and that can negatively affect cognition. We at CHOC do combined polysomnograms, sleep studies to look for things like obstructive sleep apnea at the same time as we do our long-term EEGs, and we're discovering a lot of untreated or undiagnosed primary sleep disorders. This is a cool chart down here. There we go. Just showing this kind of vicious cycle. I have fragmented sleep, either because I have an undiagnosed sleep disorder, or occasionally because my seizure medications are screwing up my sleep. I have more seizures, it lowers my seizure threshold. I have more sleep fragmentation, and on you go. And the output is excessive daytime sleepiness. I'm not doing as well in class. Adverse effects on learning and behavior. Again, we all know that because we've been sleep deprived in the past ourselves, and thus a reduction in quality of life for both the children and the caregivers who are either trying to help during the day or more likely parents up at night with your kids. So sleep is critically important. Depression is the last comorbidity I'll talk about, and it's exceedingly common. So this study here demonstrated that 23% of the youths with epilepsy in the study had depressive symptoms. 13% had passive suicidal ideation. It's a big number, and it's almost uniformly under-recognized. Depression has been shown to negatively affect quality of life, actually more than seizure burden in our patients with epilepsy. In other words, when you do a quality of life study, depression ends up being much more impactful than even the number of seizures on our patients with epilepsy. Depression can negatively affect cognition and behavior, medication adherence, sleep, can affect everything. And there's even a concept in the elderly population called pseudo-dementia, where a patient looks like they have dementia and it's mostly their depression that is actually manifesting those symptoms. Only a third of at-risk youths with epilepsy receive mental health services because of the landscape of our healthcare system. And so this is something that is under-recognized. And the depression among patients with epilepsy can present atypically. So we have to really be on the lookout for it. So key points of this section, in addition to epileptic encephalopathy, which is that modifiable component of development that has to do with actual seizure activity, there are separately other common comorbidities with epilepsy, which may also negatively affect cognition, including ADHD, autism, primary sleep disorders, and depression. Many of these present in a similar manner in epilepsy when compared to the general population, but are more prevalent and more ignored. There is an opportunity cost associated with delayed or missed treatment for these. You can't necessarily get first or second or third grade back. And so if we're not catching this and our kids are not engaging in their learning like they should be, then they're missing out, and it's hard to make that time up. So screening could be its own lecture, but suffice it to say, identifying the problem is the first step. So I'm proud to say that at CHOC, we've instituted the PEDS QL epilepsy module, which is a survey that goes out to our patients with epilepsy. So if you're a CHOC patient, you may have gotten this already on email. It looks at different domains that affect quality of life. And the idea is that we're going to start building this in to all of our patients with epilepsy and how we think about and treat all of our patients. If you're not asking, then you don't know. And so the first step is to get these data. So thank you to all of you for answering these. And if you get one and you're thinking about answering, I would encourage you to, because it's going to help. So my big summary points for the talk today. Epilepsy is a spectrum disorder, conferring an ongoing risk of seizure, yes, but also these other things: cognitive, behavioral, psychological, social impairment, which may change over time and may depend on each other or may be independent. Thus, all dimensions, all of this should be considered as potentially modifiable, and we should be looking to maximize all of these domains. We talked about the definition of epileptic encephalopathy as being the actual seizure or epileptic activity is contributing to my cognitive issues, and thus we might be able to change it, as opposed to a developmental encephalopathy where the developmental issues are baked into the underlying cause and thus less likely to be modifiable. We talked about the importance of differentiating between those two so we treat appropriately and don't overtreat. We also recognize that many of our electroclinical epilepsy syndromes sit in between those two ends of the spectrum, and we consider them as having components of both epileptic and developmental encephalopathies. Successful treatment of the epileptic activity may improve or reverse cognitive impairment in an epileptic encephalopathy, and treatment should be aggressive in that setting up to and including epilepsy surgery if it's appropriate. Conversely, in developmental encephalopathy, aggressive treatment should be avoided so we don't risk overtreatment and side effects because of that. Continuous video EEG is necessary to define the true burden of epileptic activity. So even if we're not having a lot of overt seizures at home, there may be something below the surface, and we need to check for that if there's been a change in development. Defining the underlying electroclinical epilepsy syndrome, the why is this happening, is helpful for the reasons we talked about, both for treating epilepsy and epileptic encephalopathy. ESES is one of the specific things that can manifest as epileptic encephalopathy. Again, I encourage you to watch the lecture from earlier today. Timing is important, and there's an opportunity cost associated with missing these things that we talked about, so we have to think about them. In addition to epileptic encephalopathy, there are other comorbidities that occur commonly with epilepsy listed here that we talked about today. They're more prevalent in epilepsy and they're more ignored, so we have to do a good job identifying them and taking care of them. Our overall goal is to identify and target the modifiable components of cognitive impairment, make them better. Treating seizures is necessary, but not necessarily sufficient to optimize overall outcome. And with that, I would like to open up the floor.
Hi, Dr. Phillips. It's Jana from Epilepsy Support Network, and I'm your moderator.
Here.
So,
All right. Sorry,
can you
I
hear
have
me?
all my screens going, so I'm
Okay.
focused on you now.
Okay, so we have on the chat, we do have one question,
Hold on just a
and
second, sorry.
it's from a parent who has a teen diagnosed with ESES and partial complex epilepsy at 7 years, currently 9 years seizure free, currently has a clean EEG as of 1 year ago, has ASD and ADHD. Meds are Lamictal, Neurontin, and Amantadine. If and or when should I start weaning him? Neurologists differ greatly in their opinions. Lamictal has new FDA drug alert regarding cardiac arrhythmia, which the other speakers have been talking about. So the parent is concerned.
Yeah, so I think, so we'll just start with the global disclaimer that we can't give any specific health information, but that being said, in general, we like to see 2 years of seizure freedom before we start weaning. I would say that when to start weaning, when we're considering development as an outcome, is at least in part based on underlying cause. In other words, if I have benign relentic epilepsy, or what we call one of our epilepsy continuum with centrotemporal spikes, that's something I'm eventually going to outgrow as just a matter of course. And so the idea is that I'm protecting my patient during a period of susceptibility. from both seizures and from negative cognitive outcomes if they're there. And so I would wean after I know that we're sort of out of that age window. But if it's a different etiology, if it's a different cause, then that might be different. Very generically, I would probably use the same criteria as 2 years seizure-free, 2 years clean EEG, and cognitively stable.
Wonderful. I just like to also mention, if you have questions, please put them in the chat. If you hover your cursor on the bottom of the screen, the chat box will open and you can type the questions in there. And okay, they're popping up. This is working. Okay, another question is, what is the minimum age, if any, to identify the comorbidities? What factors should be considered in deciding whether or not they should be directly treated? My daughter will soon be 4, and the doctors have identified EE as one of her diagnoses, but comorbidities such as disrupted sleep are not usually directly addressed.
Yeah, so the sleep bit, you're really never too early for that. But so primary sleep issues are going to manifest as either things that you're seeing in sleep. So my child wakes up a lot at night for no reason, or my child does a lot of snoring, or I've seen them apneic at night, or man, they move around like crazy and that wakes them up. Or they're putting in 10, 12 hours at night, but they have daytime sleepiness all the time and they take a 4-hour nap during the day as well. Sleep does not seem restful for them, right? So your symptoms that you're looking for are more sleep related, either directly or indirectly. But having one of those sleep issues decreases your seizure threshold and increases your chance of having cognitive issues. As far as the other comorbidities, autism, we can see the first manifestations of autism usually really early, but most of the inventories, the testing that you're doing for autism have a minimum age of at least 18 months. ADHD, the recommendations were 6 years for screening, or annually after onset. So if you have an early onset, we probably start looking a little bit earlier. Your biggest things you're looking for on that ADHD bit are a lot of hyperactivity, but I really like avoidance behavior as a metric of ADHD. What I mean by that is the child avoids hard work, schoolwork, avoids assignments either by disengaging or by being hyperactive, but are actively avoiding the assignments, or they're not following multi-step commands. Hey, Billy, go upstairs, wash your hands, change your clothes, come down for dinner. And then you find Billy up in his room 20 minutes later, halfway through those instructions, distracted and playing something. So, we're still looking, because all of these comorbidities manifest similarly, whether or not it's in a patient with epilepsy or not, we're still looking for the classic signs of them. It's just that I think sometimes providers sort of laser in on the seizures and ignore the rest. And so the point of this is we have to think holistically.
Wonderful. That was a great explanation, and I'm sure it was very enlightening for the person who asked the question. Let's go to the next one because we have 3 more questions. Is a normal reaction to increased medications, behavioral shifts? My 8-year-old son is on ethosuximide, Depakote, and Keppra. We increased Depakote twice in 2 weeks due to lack of seizure control. And each time we had anger issues and apathetic toward his behavior. Is this normal?
So we can see temporary behavioral changes with not only starting medication, but with dose changes. Some behavioral things are dose dependent and some of them aren't. So Keppra is classically not dose dependent. It's an exposure bit. So Keppra is, I'm gonna have my Kep rage, yes or no, and it doesn't matter how much I'm on, but every time I increase the dose, that might re-manifest before it goes away again. Depakote tends to be a little bit more dose dependent. As I go higher on it, I might have more side effects. And because Depakote, part of the mechanism of Depakote is to keep GABA around for longer, it can be kind of depressing, sedating as well. So you will find that if you kind of at high doses, if we're feeling a little bit lethargic or sedated, a lot of people are grumpier. We're all kind of grumpier in that state. And so, we have to kind of wonder if we're getting to the upper end of tolerability and some of the medication, if that doesn't go away. But we do see increased behavioral things with dose changes that typically normalize once we get used to it.
Wonderful, thank you. I didn't know, I just learned something that Keppra, it's going to always have some Keprage to it, and it's not the increase in dose, so thank you. If a child falls in the middle of the EE and DE spectrum, where do you find the balance between aggressive treatment and not treating over aggressively?
No, that's a great question. And there's a lot of, that is a shared decision, so we start with how much of the developmental bit is new. If we've stagnated or regressed over baseline, then I'm going to be more aggressive because I'm going to try to get that back. If we've always been delayed and there's no change in that, then we're a little bit more cautious. We also look at what else we're trying to do. So if we think there may be a component of EE there, but there's been no dramatic change, and I still have uncontrolled seizures, then I'm going to choose to increase seizure medication or change seizure medication and pick a spike suppressor, something that can treat seizures and the EEG. I'm not necessarily going to jump to some big crazy therapy like steroids for that because there hasn't been a change. But ultimately, it's a shared decision because your input on sort of what has been happening developmentally is key in that decision.
Great, thank you. And another question. My daughter has DEW syndrome. She had normal development, but uncontrolled seizures. In December, she went into status and had to be in a medically induced coma for a month to find the right treatment. We have now seen cognitive regressions. Are effects from status modifiable?
So the first question in that is to make sure that the effects are from the status. So in other words, we want to make sure that we've had a continuous EEG and that there's not a component of untreated seizures. There's not a component of ESES, because really it's those things on the EEG that if we think there's a modifiable component, that's what we're going to try to modify. And then through making that better, through better seizure control or through making the EEG better, we hope to make cognition better as well. There can be, unfortunately, negative effects of status epilepticus itself. And we know that intuitively, but we also know that from the FEBSTAT study is the best study that for that, which looked at children with febrile seizures who had very long seizures, in this case, an average of 68 minutes or longer. And that cohort had a higher incidence of cognitive issues and a higher incidence of MRI changes, as well as went on to have a higher degree of seizures later on. So we know that status epilepticus itself can have a negative cognitive impact, but we would be looking for those things on the EEG, and we would be looking for that occult seizure burden, those things that were modifiable, to see if we could make the cognition better.
Thank you. If there are any other questions, please post them. I'm going to pose my question now to Dr. Phillips because here at Epilepsy Support Network, we know Dr. Phillips very well. He is one of our local pediatric epileptologists and also an epilepsy genius, and we adore him. So I'm so happy we get to share him with the entire country and world through the Epilepsy Awareness Day. And I think that we're speaking at such a high level of epilepsy care and really just drilling down into the different epilepsies. I just can't go on without you throwing a shout out to, with all of these very, very complex diagnosis, I want to make sure that these families are getting evaluations, consultations, and seeking out epilepsy centers. And Dr. Phillips, would you mind just spending a couple of minutes talking about the benefits of epilepsy centers? Because that's our goal at ESNOC, is that our members and the families that we help are really achieving the highest level of care, because these are complex issues that families are dealing with, and we want them to have some relief from all of these issues. And you can see through the questions that, you know, the struggles are everywhere in epilepsy.
Yeah, so I think there's the diagnosis dimension, the support dimension, and there's the treatment dimension. So in the diagnosis dimension, you don't know what you don't know.
Right.
And so, you know, just like anything else, if you go to someone who sees something every day, they're going to be more likely to pick up a subtle presentation, a slightly atypical presentation. And some things, for instance, like infantile spasms, time is very important.
Yes.
And so, you know, an epilepsy center has the virtue of having people who do this for their jobs, for their passion. And so I would definitely recommend it for that. For the support component, epilepsy centers not only are usually linked to groups like yours, which provide support for families, but also kind of just know the ins and outs of what needs to be on an IEP, what needs to be in a seizure action plan. So many of just the normal day-to-day things that you all live, but that if someone's not familiar with, can be a real pain in the butt to get going and get it done correctly. On the treatment side, all of the different therapeutic modalities, from all of the anti-seizure medications to the diet, to implantable devices, to epilepsy surgery, all of those being on the table to get the very best treatment for our patients. I think that's what an epilepsy center offers. So for all of those reasons, we certainly like epilepsy centers.
Absolutely. And I'm doing a presentation at 1 p.m. on advocating for your loved one with epilepsy. And we'll be talking more about epilepsy centers and how to advocate on all fronts. So it'll be a kind of a continuum of this discussion, but I really wanted them to hear from you firsthand about epilepsy centers. And if our organization can help all of you get to epilepsy centers, Dr. Phillips is a part of the amazing team at Children's Hospital Orange County. We have a great relationship, and they do a superb job at diagnosing and treating. And we are in such a good place because of the collaborative efforts that we partake in. And that's what we want for all families. So if you need any help getting to CHOC or to see Dr. Phillips, please tune in at 1 p.m. For advocates across America. And we'll be talking about the strategic plan of advocating. And we're going to be introducing our new Venn diagram on all areas that epilepsy permeates, so we can take a look at it as a whole. So, and medical is the number one. So we'll be talking about that. We don't have any other questions. Dr. Phillips, is there anything else you'd like to say to these great attendees who are so dedicated in helping their loved one with epilepsies? Any words of advice?
I want to say thanks for the invite. Thanks for letting me talk about something we care about so much, and I'm happy to answer any questions. Yeah, thank you.